Should we start? We're already 10 minutes late, and Steve is worried that he has only 5 minutes left for his talk. So he told me I should be very short. And actually, he doesn't need an introduction. I know this is a sentence we all like to say if we don't want to talk too long about it. Anyway, he's now president and CSO of IDRI, the Institute for Infectious Disease Research Institute in Seattle, and actually he's the founder also. I met Steve actually in the early 80s when I worked on leprosy a little bit. At those time at WHO there were more people interested in leprosy and leishmaniasis than TB, so times have changed. I once calculated in the 80s per year $50 million total globally were spent on research in TB. So TB was integrated actually in the tropical disease groups, and that's where I heard him first time, because at that time he was in Brazil working on infectious diseases, of tropical infectious diseases, and I got fascinated. The next time I met him was actually in the 90s, when I, as an immunologist, was interested in interleukins and interleukin-2, and that is where I met him again as a co-founder of Corixa, which maybe have been a little bit away out of the poverty, tropical diseases, and more into industrial countries' issues, but you may explain to me later, not during your talk, whether I'm right or wrong. Anyway, that's when I met him second time. And then third time, now I meet him frequently, because now he is a, well, highly respected researcher in tuberculosis, but he's just one disease wouldn't be enough for Steve, so he concentrates not only on TB, but also on Leishmania, Leishmaniasis, leprosy, and what he will do today is actually try to see how we can learn, I hope so, from Leishmaniasis and leprosy for tuberculosis, with some emphasis on diagnostics. I hope I get it all right. Thank you.
Thank you very much, Stefan. Yeah, so at IDRI we focus on intracellular pathogens, and that's the common theme. My background is in microbiology, but worked with Edgar Reeby in adjuvants back in Montana 30 years ago. So we learned the value of adjuvants for T-cell immunity, and that's the common theme of everything we work on. At Corixa, you know, actually that was a company that was an adjuvant company largely, but it was kind of a Robin Hood company. You know, we made money on the cancer part, but we were able to do leishmaniasis and tuberculosis on the side. In fact, the first product was a TB vaccine that now GSK is in late-stage clinical trials with. But I really want to thank Ann for the invitation. It's great to be here, and I appreciate it. I want to talk about our experience over the last 2 or 3 decades in leishmaniasis in Brazil, Africa, and India, as well as leprosy, and why I'm interested in these biomarkers that apply. And Dr. Azar did a great job. I'm not going to go too much into the natural history, but just to point out that it's cellular pathogen. So at least with some of the HIV clades, there's something in common with macrophage habitation. But unlike HIV, this is carried by a fly, and its distribution is largely contingent on where those flies are. These are some of our patients in Sudan. We work, if you remember the map that was shown in the previous talk, we work just a little bit north of there across the border, Gadaref in that region, but also in Ethiopia and so on. And this is a map showing some of the distribution of visceral leishmaniasis, VL we call it, the blue. And then the pink is also VL, but it has PKDL, the post-Kala-azar sequelae, the dermal leishmaniasis. But what I think is interesting, and I think you'll come to see it a little bit later, in how we try to take advantage of for-profit and non-profit activities to serve the goal, which is not neglected diseases and disease of the poor, is that leishmaniasis in the 90s was recognized as a major opportunistic infection in Europe for HIV. And in fact, in Europe, it's a different parasite than what you see here in the Africa and Indian subcontinent we just heard about. It's really L. infantum, and that's what's in Latin America and Europe. And it's called infantum, as you would think it's because of a disease, mainly a pediatric disease. It was brought over to South America by the Portuguese in their dogs. So the other difference between the African form and the European form and or South American form is that dogs are a reservoir. But the fact that it's an important HIV co-infection in Europe has led to the development of new diagnostic tools and And I think there should be more activity there, because if you proactively detect infection in an HIV-positive individual, you can proactively do something about it. But right now, we only have diagnostics for disease. And you saw a nice video of a splenic biopsy. This is an algorithm that's often used in Africa, Sudan, Ethiopia. Obviously, this is for acute disease, and this is what we set about 20 years ago to develop a test for. And we came up with this RK39 test, which is now the gold standard for detecting serology that's pathognomonic for acute visceral leishmaniasis. And in India, at least, this has replaced parasitology and the left node and bone marrow, although some people still do these tests, either for lack of access to tests, which I'll talk about, or individual preference. K39 was an antigen that we cloned several years ago, and it was a collaboration between IDRI and the Federal University of Bahia. This was an expression clone project. It's quite simple at the time. Well, quite simple now, but at that time making a library and, sequencing genes was not trivial. But this was a dominant repeat antigen, and what you'll see in a parasitic disease is there's a lot of tandem repeats that are immunodominant. We can take advantage of that for diagnostics. However, they're very poor T-cell antigens. They don't do well in the vaccine department. So there's been a lot of tests. What we do at IDRI is we specialize in biomarker development, and then we license them out to companies that will make an actual test. And that's always a challenge, because they don't make any money on these things. So we have to incentivize them in another way. For example, the company that produces this, I give them a better deal on tuberculosis antigens and things like that, so that they'll provide this for virtually no profit. The K39 test, it's an interesting little story, and where the European connection of elinfantom comes in is we actually cloned this when we were working with people in South America on elinfantom, and as I mentioned, it's a disease of kids, so you don't get much from them. In other words, I was always wanting a little bit of serum to do some serology or some T-cell work, to get some blood, do some T-cell work. But you can't really get much blood, and it's unethical to try to get more than an ml or so. But serendipitously, about this time, the CDC called and said they had this case that they couldn't quite confirm, and it was an American, actually a professor who had been vacationing in Greece, and he was a dialysis patient. So when he came back, he went under immune suppression for kidney transplant and developed this horrible infection they couldn't figure out. But due to his travel history, they called me, and so we quickly did a Western blot and said he has leishmaniasis. Well, he was so grateful after he got treated that he allowed me to leukapheresis him, and got enough serum to actually screen the library to actually clone these genes, which then could be applied to a diagnostic test. So the K39 test has been out there for about 20 years in a variety of formats. It was cloned from serum from one individual, but it's such a well-conserved antigen that it picks up all L-Doner body infections. And then later we published a little paper on its ability to be reacted with in HIV patients from Europe. Although, as was pointed out in the last talk, since it is HIV, it's less than optimal to use an indirect test in this situation. However, the advantage of using a recombinant protein is the titers are so high to this that even in a face of immunocompromised situation, you have, this paper pointed out, at least 80% sensitivity. Not as good as the 98% or so sensitivity that you have with non-HIV patients. So this is these are a couple of the formats. This is licensed in Brazil, ChemBiotest. These guys in Long Island that make this. And this is a Seattle company that makes a single dimension rapid diagnostic test. It's FDA approved and licensed in many countries in the world. But it was pointed out in the last talk as well, there's somewhat less sensitivity of the K39 test in Africa than there is in India, so we have a next generation that we developed, but that's another story. The impact of K39 in the field has been replacement for crude diagnostic tests. So the direct agglutination test is a whole pro-mastocode, a whole parasite test, and basically it's based on agglutination. As you can imagine, these plates are provided with whole parasites and they're not very stable and they have to be refrigerated. It's not very good for field use. And it's a non-quantitative test. It's subjective. You have to kind of determine, well, is this really a positive here or is this not? So your cutoff is going to depend on a subjective reading. So in India, they've put out this guideline in the National CAL-AZAR, which is visceral leishmaniasis control, saying that it was concluded that the K39 test is comparable to parasitology. Sensitivity can replace parasitology as a basis for decision to treat VL. So now if you come into a clinic there, being in India or Bangladesh, the K39 is the front line that's used, and if you're strongly positive, you're treated. They don't bother with a bone marrow biopsy. And I was very happy to go to Bangladesh last summer, and this is a director of a hospital there in the field area, and there's all these little tests written on the wall that they provide, but the patient has to pay a copay, and this is maybe 15 cents or something. Cholesterol, I don't know, 50 cents. But I was very happy to see at the bottom here that our K39 test is provided free of charge by the Bangladesh government because we provide the technology free of charge. I did something wrong, so I got to move this here. So, yeah. Anyway, serology is great for leishmaniasis. For TB, we use T-cell assays, mainly for the quantiferon tests. But, you know, in leishmaniasis, it's a much bigger genome, and we don't really have that strong T-cell response to individual antigens like we do in TB. So we've tried pretty hard to make a quantiferon for leash, but have failed. You can do it with crude antigen, but it's not amenable to a real test. So I've focused a little more on direct diagnostic tests recently, as opposed to the indirect. Indirect meaning you measure a response, either serology or T-cell. The direct diagnostic tests detect urine, protein or nucleic acid. And this is obviously applicable for HIV co-infection because if you're doing a urine test or a PCR that depends on detecting parasite or parasite products, the immune response doesn't come into play. And so these are probably going to be much more relevant for a co-infection type test. More recently, we've done some PCR, and I'll show you some data there. And we're about to launch a urine antigen detection test for VL. And I'll show you some of those data. In fact, here they are. This was a test that we worked on for quite a while with using monoclonal technology and so on. We collaborated with Antonio, who's here, who had some very nice monoclonals as well. But for our purposes and to make it cheap and to make a very high affinity antibody, we focused on rabbits, polyclonal, to certain antigens that we had. And basically found that most of the urine samples from acute visceral leishmaniasis, these are from Brazil, these are Brazil healthy controls, from Bangladesh endemic controls, and Sudan, most of them are positive on the test, which surprised me that there's so much antigen in the urine during acute infection, or acute disease, in fact. But the test isn't perfect yet. We're still working on it because we do pick up some false positives here. And I'm not sure about the false negatives. We think these are real VL, but we're having that confirmed. But so far it's been put in a prototype package for field tests, and this is again that Seattle company that makes these little kits. And kits are great because if you don't do this, then everybody has their own little method, and you really can't figure out if you're going to get a product or not that's available for neglected diseases. What's interesting is, and these are data that were collected actually, I think, from Gundar's urines. They were sent from Ethiopia by a couple different collaborators there, but you know, I'm not sure. But basically, these are pre-treatment samples that were from visceral leishmaniasis from Ethiopia, and then day 30, and then day 180. So you see the antigen goes down in the urine with successful treatment, which is great. And we compared them to the other test that's out there, which is called KTEX. It's kind of a first generation antigen detection test, but unfortunately it takes half an hour, which isn't bad, but it takes a long time because you have to boil the urine first. These are carbohydrate-based antigens that they're detecting. But the real problem is the sensitivity is very bad, about 50%. Specificity is good. We have to work on ours, but at least we're getting very good sensitivity, and you know, the kit is easy. You don't have to boil the urine or anything like that. So it's very promising. And I think Antonio's doing something that should be very promising for our TB. You'll probably hear about it in the future. Oh, I messed up again. But again, if you have HIV and TB, this could be a good way to detect TB antigens because you're not going to have a good skin test and you're not going to have a good quantiferon, as we all know. So antigen detection is great. But the other reason we're very interested in detecting asymptomatic infection, in fact, the real reason we started going this route of detecting asymptomatics, I mean, in HIV, we've done it for a long time. We want to know if you're HIV positive or not so you can do something about it. We don't just wait till you have disease to make a diagnostic determination. But in leishmaniasis, Chagas disease, we don't do anything. We wait till there's a disease. But gee, just like TB, 90% of the people infected with leash aren't sick. So they're out there. What are they doing? Well, you know, what am I doing? You know, they can be reservoirs, right? The fly is getting them from somewhere. And I told you about dogs in South America, but in India and Africa, it's the humans. So it makes sense that some of these people walking around with parasites could be reservoirs for the fly. I'm going to quit leaning on this. But also, they're going to be at a higher risk of developing disease. So it's nice to know if you care about, you know, if it was a developed country disease, we'd actually screen for it. We say, oh, you got a high risk of getting VL, so we got to make sure we cut it off at the pass. But you can't do anything about it right now. So if in this country we do a skin test, you got TB positive skin test, you go on INH orally for 6 months, and you can't drink wine. And it's a relatively safe and cheap way to prevent progression to TB. But we don't have a safe, effective drug. You heard in the last talk, these are toxic, they're intravenous, they're expensive. So what would we do about it? Well, we'd watch and wait, or we might be able to use them, these people, these asymptomatics, to design effective efficacy trials. And that's what I really wanted to talk about with some of these asymptomatic markers. Because when we start thinking about vaccine development, we get some results in animals and we're all thrilled. But, you know, especially something like leishmaniasis, we never stop to think how we're going to test this vaccine in the field. You go to Bihar in India and you see a few cases in a village, and you drive for 4 hours and you see a few cases in the next village. And the design of a study in uninfected individuals would be daunting. You would maybe be able to do one. And if it didn't work, you maybe wouldn't have a vaccine produced. So what we're trying to do is enrich the target population for those most likely to progress so that we can lower our N by a factor of 10 to design what I call post-exposure prophylaxis, which we all call people that are already infected, but you want to head them off. These people have a 6 to 10% chance of developing disease in 18 months. So then you can design a study with 500 per arm, placebo versus vaccine, as opposed to maybe 3 or 4 or 5,000. In fact, the last one we designed for random individuals in an area was 15,000 people, based on the incidence and the variation season to season. But the other reason you really want to detect asymptomatic individuals prior to large-scale vaccine development is because when you start going into a population of vaccinating them, some of them are going to be infected. And TB, it's exactly the same. We're talking to our collaborators in Cape Town, and you know, we don't really know these very early infections. How many people are infected if we don't have a positive quantiferon, and some of them are infected before they have that. So you're going to want to define in an already known positive population, are these vaccines safe? And especially in TB, where you have this shadow of the Koch phenomenon hanging over your head for the last couple of centuries almost. So safety is one very important reason, but designing a trial is the other reason that we look for markers of asymptomatic infection. So at IDRI we've developed tools, and what we hope to do is increase our pipeline of products, not only to have markers of disease, because what we set out to do 20 years ago is provide the docs with something convenient so they wouldn't have to hold down a kid and stick a needle in the bone marrow, or in the case of what you saw in Africa now in spleen. That was for VL, acute VL, so K39 was developed as a disease marker, not as an infection marker. Now we're going back and saying, can we get infection markers? So what can we do to complement K39? Because it does pick up some early infection, diseases and late infections. What can we do to complement that antigen and develop quantitative tests? And so there's a lot of different approaches that have been used, bioinformatics, mass spec, and expression cloning. and then looking at these panels. And what we look at are really who are we missing by the existing tests? Who are we missing by K39, which again was developed for disease, not infection? Who are we missing by DAT, which was developed for everything? And can we improve on that and make a very simple to use ELISA or rapid test with recombinant proteins? This K39, if it's not provided for free by the government, it's cost about 60 cents. That's with very, very little margin. Where this costs more and you have difficulties using it, has to be refrigerated and so on and so forth. So in a nutshell, most of the antigens don't work, and we've screened through hundreds of antigens. I've been doing this for a long time, and they either don't work because they don't react well on asymptomatic, and we know they're asymptomatic because they're either PCR positive or DAT positive or some other serological criteria, or they're just too noisy. Their background's too high. On other diseases, there's a related parasite, T. cruzi or normals. But we have come up with a few antigens. One is this tandem repeat, and this is where it gets kind of interesting. If you look at DAT positives, it picks up, this single antigen picks up about 90% of them. Remember, DAT is a whole parasite, so if you have a single antigen, it picks up about 90% of them. But what's really more interesting is it picks up over 80% of the ones that are missed on the DAT. And these, again, are either they're confirmed by PCR or some other method of having asymptomatic infection. And then there's another antigen, number 2, that gets all of the DAT positives, but 97% of the DAT negatives. Very promising. And great background on defined normal sera. Now we have to go into the field and see if it picks up any asymptomatic, but endemic disease normals. But what I did mention is we go through all these antigens and we do a lot of bioinformatics to make sure they're not conserved with common pathogens in the area. So basically we come up with combinations that can complement K39 test and basically give you a screen. And the next step is we will develop a K39-like rapid test and a rapid ELISA for asymptomatic. Right now we've got about 96% sensitivity, not as good as we'd like. But again, it's a little bit hard to find sensitivity here because you don't have a gold standard of a bone marrow biopsy or a splenic aspirate like you do in acute disease. Are they really infected or not? You have to take an indirect test or another measure to make that distinction. But I think we're pretty close, and we'll be able to come out with a screen pretty soon. So how are we going to apply these tools? Well, this paper was just published from Bangladesh, where we went out and screened about 4,000 people. The only test we had at that time was the rapid K39 test, and so we only picked up 10% of these as positive. But that was even high because, again, this is supposed to be a disease test, not just an asymptomatic test. I think if we go out with our next generation, we'll find more of them. Anyway, of these, most had no previous history of VL, and of these, we got 56 where we had both a baseline and a 12-month follow-up sample. And that becomes interesting because, as we knew from our studies in Brazil back in the 80s, wow, yeah, 80s, most of the people that have infection are not disease. So that's why we published that the infection is the bottom of the iceberg, so to speak. But in the same thing we saw here, all these are healthy, asymptomatic, but of 47 that were PCR positive at time 0, over 12 months, 40 of those were PCR negative. And this is just either it's a combination of Buffy coat and whole blood PCR with a small sample of blood. So it blew my mind that actually we'd pick up this many. Remember, there were 56 total that were positive with DNA in the blood. Of these 47, 16 persisted PCR positive at 12-month follow-up. And of those, 5 have already developed disease. So now we're getting there. So now, over 18, as I said before, over an 18, maybe 24-month period, you may have enough individuals selected with a high enough percentage of developed disease that you can design an efficacy trial with a few hundred people per arm. And we've done the statistics, calculated 6% over 2 years. We'd need about 500 people per arm. And we're doing something very similar in leprosy. Leprosy is an issue because unlike TB, you don't have a lot of organisms. So we had to really work hard to make a sensitive test. And what's the idea here? Well, the idea is to intervene again before you get disease. There have been some studies where they go out into an endemic area and give everyone mass therapy because leprosy, like TB, has good drugs available that are cheap and easy to administer. However, you take them for a long time, and we don't want any drug resistance, so it's not a good idea to give them to people that aren't infected or don't have a very, very high risk. So what we wanted to do is use a diagnostic test to detect infection in contacts. This could be household contacts or it could be school contacts, but mainly kids that could be exposed to leprosy and detect them very early. And to do this, we developed recombinant antigens again, but we combined them with this cool little reader that was developed by a friend in Brazil. And it uses a smartphone, and you just stick your rapid test in this reader, and you get a quantitative test that's sent to your database. And then you've got some combination. It's basically just as sensitive as an ELISA, and I'll show you some data that were generated in Brazil recently. I think they were published. But this is a case study that we published not too long ago with a little girl in India, or in China. And basically, you know, these are her serological responses to what was the old leprosy test and what we developed. And basically, as you can see, we were able to detect antibodies several months before the onset of any lesions. So if you can do that, you can start intervention very early. And if it's negative here, you keep testing it maybe every 6 months or a year, because we're not going to get 100% sensitivity with this disease. They have very low antibodies. But at least you can make a serological diagnosis before a clinical diagnosis. Now, it doesn't mean they're going to have leprosy. It just means they have antibodies. And some of those people will never get leprosy. But since you've got a rapid and cheap way to intervene, you might as well know that they have infection to either watch and wait or to intervene. And this is a study that we did in Brazil comparing ELISA, which takes 4 hours on this lipid-based antigen. You pick up the lepromatous and most of the possibacillary leprosy patients, and not too much of the controls. But what we got is a higher level of sensitivity in 15 minutes when we combined a rapid diagnostic test with a smart reader. Now, this smart reader is going to be given away like a bunch of razors with the razor blades. It won't add a lot of cost to the test, and I think it'll be a government provided test, but at least it'll have something that can be mass produced and produced locally, and can start using for screening. And the idea is, what would you do with this? It's not exactly like TB, but I'll get to that in a minute. We go out to an area in surveillance. These are contacts, as I mentioned, okay? If they're positive, you treat. I mean, positive basically on a clinical exam. If they're negative on the clinical exam, what do? Well, we can apply our diagnostic tests. All we got right now is a little serology. There's no skin test for leprosy. Can't grow the organism. They've been using a chopped up bacilli from somebody else's lesion, but I don't even talk about that. We're making a recombinant-based skin test, but it'll take a little while. But if they're positive on your diagnostic tool, then you can do chemotherapy, prophylactic chemotherapy, or immunochemotherapy. I would propose that we take a vaccine, either BCG that's used now in Brazil, or the new one that's coming along, and immunize and chemo at the same time on day 0 and day 30. If they're negative, watch and wait. It may not be worth treating everyone, as I mentioned, if they don't have any signs or symptoms. Now, in TB, and I'll talk about this a little bit tomorrow, we're doing something similar in Cape Town, where the goal is not to immunize everybody, but to immunize people at a high risk of developing TB. And the population we've chosen are individuals that got tuberculosis. We treat them, then we come back, and after the treatment is ended, we vaccinate them because they have a higher propensity to develop new disease within a 2-year period. So these tools are incredibly important, I think, to be able to not only detect disease, but detect infection, and then to be able to do something about that infection, whether it be prophylactic drug treatment or, as I mentioned, designing of clinical trials. Most of this work was done in our collaborators at the International Center for Diarrheal Disease Research in Bangladesh. If you haven't been there, you should go. It's fantastic. We just had a big NIH meeting there last month. Even Carol Howellman showed up for that. It was great. Collaborators that make the tests, and then our collaborators in India as well. and Bill and Melinda Gates Foundation has funded some of the field studies. Thank you.
Thank you. Excellent timing.
I do. I saw you watching your watch.
Well, these are small tricks which I learned during my life. Questions, comments? Yes, please.
Do you see the smartphone beginning to play a much bigger part in diagnostics?
Well, you know, I was so frustrated because I brought this concept to Gates Foundation and they said for Africa, nobody has a smartphone. Ha! Now I have a collaborator in Cape Town who's distributed and used ones all over the continent. They have even an industry where they get them from Europe. That you trade in your old model and run. Yeah, definitely, I think so. I mean, everybody wants one in these countries. I just came back from Brazil this morning. Everybody's got a smartphone. And the trick has been these adapters. It's been frustrating, but now there's at least 2 good adapters there, and they're manufactured in China, OEM. So they have to get out there, we have to publish, but I think it's very nice because, especially in a low antibody response situation, you've got to guess, and you don't want to guess. You want to be able to establish a cutoff and get a value and send it to a database.
So what's the expected cost of this small adapter?
Well, it's about $100, but as I said, it'd probably be if somebody buys a 500 test or something that's provided. Yeah. The phone is an extra $200 right now, but they don't have a phone.
Yeah.
So if you have
Can you wait a second? Sorry.
If you roll out your serologic test for leprosy, and maybe you know this already just from existing tests, what is going to be the rate of evidence of exposure without any evidence of disease? Is there going to be...
There's no gold standard right now. It's a great question. So the test was rolled out in Brazil. It was launched last year. It's been criticized because nobody knows exactly what that positive serology means. So we're having to do what Abbott does in the case of Chagas disease, which is a confirmatory test. So if you got confidence that there's antibody there, I think that we know our specificity is very good. These antigens are just not shared. So then you know there's an infection that's occurred. That's the only.
But how many? If you just did a seroprevalence study, how many people would be serologically?
In a population that's not enriched for contacts, it's.
Yeah, or in contact.
In contacts, it's very higher than you would think. It's 15 to 20%, depending on how long that they've been in contact. You know, if it's a school that's been with the same people for a year or two, it's much higher in the household contacts as they're always with their parent or sibling. It's 30%. But of those, most will not get disease. But we feel that it's if there's a safe intervention that you can do, it's worth taking it because it's such a devastating disease. They still send the kids away. And
so Steve, let me go to TB and antibodies. We had that discussion briefly today, and you think that, and you know also that there are people who favor antibodies. We know also that the WHO kind of was very critical about the misuse of antibody tests which have not been validated. Also, that's nothing against antibodies. This is just against misuse of tests. What's your standpoint? Obviously, it's an attractive.
There are a couple, antibodies for diagnosis, I think, should be included in a workup. I really do. I started doing this when my wife's father died of TB in Seattle, and the diagnosis came back positive 2 weeks after he was dead.
Yes.
And I suspected it because he was from Japan, but it was extrapulmonary. So as you know, Stefan, there's a lot of extrapulmonary TB. Now, it hasn't been a big priority of the Gates Foundation because they don't transmit, but these are patients and they need a diagnostic test. I was on that committee at TDR with Rosanna. The committee started out by doing exactly what you said, trying to discourage bad tests that were very low in their specificity and sensitivity. But after we all left and TDR committee got disbanded, the publication came out And manufacturers took it as a recommendation not to do serology at all, which was very distressing. So we're rethinking the whole thing with new data. Unfortunately, we haven't got an antigen combination right now that's higher than about 85% sensitivity. But still, I went to the Philippines with a prototype test, Steph, and I said, I'm sorry, this is only 80% sensitive. He said, are you kidding? If I can triage that many people on the spot and treat them and send them away with drug, you know, it'd be a miracle, because a lot of them don't come back by the time they're here. So I think serology should be included, as long as we're confident in it and the specificity is good.
Yeah. And using antibodies for glycolipids, which would be the other way around.
Well, you know,
I mean, this was in the 80s. Everybody
Yeah.
dreamed of, what was it, phenolic glycolipids and
PGL.
urine and so on.
And
PGL.
that's where leprosy was. So that
Yes,
test that I
I know.
showed you,
Yeah.
that's a PLG test. In fact, our LID1 isn't pure recombinant protein. It's conjugated. Patrick Brennan, you know, he was about to cry because he was conjugating this PGL to a BSA protein to get it to stick. I said, Patrick, we'll clone antigens for you from leprosy and use those instead of BSA. So I think they play a role. We like to have protein and, you know, early and later type antibodies.
But what you say here, I mean, I'm not talking about, so you would look mostly for diseased people. For latency, to distinguish that, would you expect any glycolipid or any MTB molecule appear in the, MTB-derived molecule appear in the periphery?
You know, our experience with that has been it's much harder to get specificity in asymptomatics for TB than for leprosy. Probably because there's so many, you know, environmental mycobacteria. Fortunately for leprosy, we're able to distinguish from the environmental mycobacteria. For TB, we've been unable to find TB specific that are in the asymptomatic. But it shouldn't be given up on.
Yeah, it's my understanding that in the island nation of Kiribati, there was an effort made to sterilize the population for leprosy. Do you know anything?
The Western Pacific region, right? It's near Samoa or something?
Well, it's like 3,000 islands.
Oh, okay. Yeah, I was at the Western Regional, and I heard about that study. Basically, yeah, mass rifampicin study, and there was something like it done in Nepal. They call it a CONLEP study.
Right. But as soon as the effort was ended, the disease came back.
That's right.
And do you know whether that has been followed up? Was the disease now drug resistant?
No, not that I know of. It hasn't been resistant, but I know that nobody wants to do that study anymore. There was a recent one done in northern Bangladesh because they're worried about the resistance. But as far as I know, it hasn't been reported. But that's why we'd like to combine that with the vaccine if we can, because what we have now is a transient interruption of disease progression, but we don't have a permanent one with chemoprophylaxis.
Are there is there molecular understanding why drug resistance is that rare in M. leprae? I know it has a small genome, I know it slowly divides, but is that all one needs to know, or is there more?
You have to ask people that know more about this, but I think that's part of it, the replication.
I was asked to ask difficult questions.
Yeah, ask some. Peter Small keeps saying it's going to be evolved out of existence, but I don't want to wait that long.
Yeah. Very good. Okay, further questions, comments? No? So there's a change in moderators, I understand. So moderators come up, and I pass the